Hi, this is Doug Eby. Can you hear me?
You sure can, Dr. Eby.
Okay, slides up. So our story is taking a whole medical system, again, a mixed payer environment, which I'll try to get to and explain, and then taking the entire system and redesigning it from stem to stern and running a very primary care-centric thing, which is why the title is Massively Powerful Primary Care. And one of the great things I believe very strongly is that primary care has largely abdicated its role in this country and actually literally all around the world, and that's extremely unfortunate and not something that has to be. Our company it's a private company, locally owned, consumer-owned, and consumer-driven. We employ about 2,500 people. Our sister corporation, the Alaska Native Tribal Health Consortium, employs about 3,500 people. So thousands of people supporting hundreds of thousands of people in a whole system approach. The way to get to primary care that actually works, though, is to rethink everything about primary care and to base it on a very different paradigm, and then to pull in all other services. This business of over-specialization and specialists and so forth, we'll get to that in a little bit, but it's a huge part of the problem. And if Bob Berenson is still on the line, even your issue with the physiatrist and the role of the physiatrist, we have an answer to within our system. So the reason a lot of people listen to us is because we have actually produced, sustained over decades, the triple aim. So we've dropped dramatically use of specialists, ER, and hospital stays and emergency room visits while improving financial performance, dramatically dropping cost, very high satisfaction by people working for us and people getting services from us. And our population is a high-risk, challenging population, and we've moved from the bottom 5th percentile to the top 25th percentile, so at the 75th all the way up to the 99th percentile, pretty much every single clinical outcome that you can measure. And just to say something about measurement, the classic medical outcomes we're happy to be accountable for. We want to produce other things, and too many people talk about primary care as if its main purpose is screening and prevention and health, which we certainly believe in, and those are priorities for us. But the big return on investment in primary care is in health, well-being, and chronic conditions, and dramatically decreasing the use of expensive things. So you can get a 6-month return on investment by massively increasing your investment in primary care, while also getting decades of improvement in other things. It's the whole package. So here's the other set of measures we think are extremely important. In fact, these are more valuable to me than the health outcomes to some degree. That availability is extremely high, cultures and traditions respected, 97%, trust, 99%, provider listen carefully, 98%, I got the right amount of attention, 97%, I was given enough information to make my own decisions at 98%. That's just remarkable. We also are the only healthcare organization in the entire United States to have won the presidential National Malcolm Baldrige National Quality Award. This is one of the most difficult things to get. Still the only healthcare organization in the country to actually win it twice. And so we didn't get this by being the cute little native place in Alaska, but by actually doing transformative work sustained over decades across thousands of staff and tens of thousands of people using the system. The financial environment, just so people don't write us off as something unique and weird, over half of our money comes from visit-based volume fee-for-service, terrible way of getting paid. We get a block grant from the Indian Health Service for the tribal part of what we do. We also get money. We run 14 FQHC community health centers. We provide thousands of veterans, native and non-native services. We are big players in behavioral health and addictions. We also do lots of research, and of course, we pursue grants and philanthropy and all of that kind of stuff. In terms of costs, we cover all costs. So everything from medical visits to pharmaceuticals, expensive residential treatment programs, addictions, optometry, dental, the whole 9 yards. And if you look at our per capita spend, despite being the most expensive state in the U.S. in terms of per capita spend on average, we are at 2/3 the average for the entire U.S. So remarkably better outcomes in a dramatically challenging physical and social complexity environment for less cost with top-of-the-line clinical outcomes and satisfaction. We do it through a transformation of an entire system. This is just a picture to let you know we are a big system. We and our partners run a big tertiary medical hub. support lots of satellite hospitals in addition to clinics, and then tons and tons of community-based people, expert patients, and lots of team-based approaches. Of course, in Alaska, it is always beautiful, and the mountains are always fantastic. The core problem across the entire world, and because we become a little bit famous, we do consulting and advising literally all around the world. And so we have interacted with health systems all over Europe and Southeast Asia and also, South America, all kinds of different places. And there are two big problems. One is how money is used and distributed. And by the way, I agree with Bob and others that individual pay for performance is corrupting, awful, evil, ought to be burned and torched and dismissed from humanity. But there are lots of things about how money is messed up in lots of other ways, which is a whole conversation in and of itself. But the part that's often missed is this other part, which is the over-reliance and consuming belief in the medical model. So even when we work with single-payer systems in Europe and Australia and New Zealand, they are actually the most interested in us in what we've done because they have not messed up the money side as badly, but they're still thoroughly messed up in this over-reliance on the medical model, the idea that the body's made up of parts and centers of excellence and specialists somehow are the answer, and that you must come to our physical temples and follow our rules and get naked and do all kinds of things in order for us to do anything worthwhile. All of that's just complete crap. And the idea that then we judge people, so we are the all-knowing people who give you a diagnosis and a treatment plan, and then when you don't perfectly do what we tell you to do, we call you non-compliant in our authoritarian, arrogant, narcissistic, and completely offensive way. So let's talk about what we do instead. So I agree very strongly with our first speaker, Christine, this morning, who was talking about relationship and connectivity and so forth. We believe that that is the fundamental core of the business that we're in. Relationship, shared responsibility, the idea of customer ownership, connecting through story, and deeply understanding what complex adaptive system theory has to tell us and so forth. So let's explore this a little more. This is always my favorite slide. On the right hand is high acuity environments within which using Six Sigma manufacturing processes and so forth makes sense because the patient, or what we call the customer owner, has little to say and we're doing things to them. But in most of healthcare, it's the other end. It's the lower acuity, people living with chronic conditions and challenges, either from simple to complex. And in that reality, the people in charge are the patient or the customer owner or the individual and the family, influenced by their environment, but they're making all the important decisions. Do they pick up their meds? Do they actually take them as prescribed? If they get, 20 different medications from 7 different specialty protocols that they go see, because of course we have to fragment them in modern medicine. The people who decide what they actually take and don't take is them, influenced by the people around them. They decide what they eat. They decide about drugs and tobacco and sleep patterns and exercise and how they handle frustrations and anxiety and tension in their lives. Those things are under their control. The only question is, how are we going to respond to the fact that they are in control? So what happens then is understanding that just medical people doing whatever they want, that's chaos in the top right-hand side of this Stacy diagram. And modern medicine's answer has been to try to protocolize and standardize everything, which is on the bottom left, and all of a sudden manufacturing and Six Sigma and Lean have become the answer to everything. Well, that's also crap, because that works for 1/3 of what we do in healthcare, which is in high acuity environments where the patient or the customer owner is passive. It does not work for 2/3 of the cost and 3/4 of the people involved in healthcare. You need to be in the middle. And this middle area is called complex adaptive system theory. I'd love to spend a half an hour on it, but I get very few minutes here, so I'm going to move along. But basically, everything about how you get excellence in relationship-based primary care is almost the opposite of what modern medicine is preaching these days with the Six Sigma Lean and all that obsession. We're big believers in that, but only for 1/3 of what we do. For 2/3 of what we do, it's almost exactly the opposite. Which leads me to this slide, which is healthcare is about 1/3 manufacturing and ought to use manufacturing excellence models for what they do. But that is not where primary care lives. Primary care lives in the part where we walk with people over time with their challenges. And that is a service industry platform, which means complex adaptive system theory, a whole different understanding of the business we're in and what excellence looks like and what methodologies and tools are actually going to stand us in good stead. Again, a whole presentation to be done there, but moving along. This is what we've actually done in primary care in terms of structure. We have said our job is to be your lifelong companion, partner, advisor across all service categories and locations, never leaving your side no matter where you are in the system, and providing that advice, coaching, support, and cheerleading, and then drawing services to you and us in that partnership, which means a complete reconfiguring of the entire medical system. So let's build this from the core up. So you have the customer owner and their family in partnership with the primary care team, which to us means a primary care provider, a case manager, supported by CMAs, and what we call case management support, sort of our own little local invention. And then each of them have we're down to just around 1,000 now, so this slide's a little bit old. We keep shrinking the panel size because to do outstanding work, you have to have the availability and time and energy, so you need really small panels. So we're at about 1,000. And so for every 5 or 6 then of these teams, there are 2 behaviorists, a pharmacist, a dietitian, a couple midwives, and actually now a social worker. And I'll get to lots of other integrated co-located specialists as well. And then there are coverage people and so forth to help them do their work. All these people exist only to interact with the people that are connected to them. They have these other people do not have separate rooms. They do not have separate schedules. They're in the same physical environment, 2, 3, 4 feet away from each other. So very congested COVID sharing environments. Haha, that's a joke. So this is then sort of the diagram of the whole system. So customer owner family in the middle with their never leaving their side, always present primary care capable team that they know on a first name basis and know them on a first name basis. All barriers to access removed. For over 20 years now, we've guaranteed same day access 5 days a week, all day, every day to these people who know you by any modality you want. Phone, text, email, in person. It's up to the people to decide how they want to interact. For 20 years, unfettered, unblocked access to people who know them. And then co-located are a whole bunch of people, which I'll get to in a minute, and then reconfiguring even the specialists who are not co-located, which I'll get to again in a minute. So what we've done, made fully accessible, relationship-based, completely connected, first name basis, available to you however you want to be connected to, all day long, every day guaranteed for over 20 years. And then we've layered in expertise. So rather than sending you to experts and centers of excellence, by the way, the whole idea of centers of excellence and specialist-centric thinking and structure is just offensive. It's just terrible. It's inefficient. It's dangerous. It's ineffective. It's fragmented. It just makes no sense at all from a human design perspective. So we've pulled specialists into our physical space and integrated them. So we have HIV specialists, diabetes, obesity, chronic pain physician, chronic pain psychologist, physical therapist. We have complexity expert, adult experts, pediatric expert specialists. We have aging and well expert, palliative care, psychiatrists, addiction specialists. We have all these people, lactation specialists, midwives. They're all physically in primary care, and their entire purpose in life is to help the generalist platform do outstanding excellence for everyone, no matter what their complexity and what their diagnosis. So there is another layer of other specialists, right? The cardiologists, the neurologists, the pulmonologists, the ENTs, the orthopedic surgeons, and they are not physically in primary care, but all these people are physically in primary care. So those other specialists, we've just had to retrain them to quit being center of excellence destination people, to instead be facilitating, coordinating, supporting, teaching, consulting supporters. And we've done very well at that. I'd say 90% of our specialists understand that their job is to be immediately available to this generalist platform whenever they need them. So like our cardiologists understand that if they can connect by phone or video to a real conversation in real time that's happening between the primary care people and the customer owner, if they join in real time within 5 minutes, they can avoid 80% of the visits to their office, leaving time then to do the stuff that they have to do in their office. And since everyone in our entire system works on salaries and there is no perverse pay-for-provider crazy crap distracting them from what they ought to do, they all do the right thing. We run the system with global budgeting and global planning and global thinking so that there are no perverse incentives built into the system at any level. But again, remember, we are mostly still in a fee-for-service environment and so forth. There really isn't much managed care in Alaska. We do get some block grants from other people, but it's still mostly fee-for-service. But we think and act as an entire system. We budget as an entire system. Revenues are shared across the entire system. So we do the right thing and then figure out the money. The reality is we lose tens and tens of millions of dollars in revenue that we would be making if we ran in the usual way. But we've also dramatically reduced costs, somewhere to 34 to 40% reduction in per person cost because of how we think and act. And this is a simple financial math that modern medicine does not seem to understand, which is if you drop costs faster than you give up revenue, your margin still improves. So we can come back to the money side if you want, but even in our crazy financial environment, we've made this work very well financially. So then in addition, we have home visiting people in all sorts of different categories. We have social workers, community resource workers. We have learning circles. We have tons of lay experts, expert patients. We have over 75 different types of learning circles run, all different locations, all different times during the day that are run by, quote, expert patients or community members supported by our staff in a very sophisticated way, which I don't have time to expand longer. So the principle here is the people are living their lives, and it's our job to weave our services and expertise into their lives at their convenience with people they know and trust on a first-name basis, who then pull all other expertise and resources into that relationship. So we've eliminated disease-specific approaches and only do whole-person work. So we pull specialty stuff in, and then we have this massively capable primary care. It turns out if you don't artificially constrain the system, yes? I'm down to my last 5 minutes. I'll finish.
We've got about 3 minutes left, if that's okay.
Yep, nope, and down the home stretch.
Thank you, sir.
So if you don't mess with people, it turns out that if you let the system be consumer-driven, you get about 50% asynchronous and virtual, text and email, 30% synchronous virtual phone, video, 20% visits. This is not created by us. This is in response to how people want to interact with us once they have long-term trusting relationship. Completely consumer-driven system. This is the physical environment within which people sit as teams. We have to then retrain all of our staff in the ability to give and receive story, deeply understand who they are, constructive conversations, coaching, advising, mentoring, and so forth. We have a massive workforce investment, an entire building based on nothing but changing the habits and knowledge and skills of our staff, deeply embedded in this idea of customer ownership. We teach them a lot of self-awareness and self-knowledge, but also how to connect and so forth. One specialty story, just to give you some data. So HIV, we don't get to fire anybody. This is all comers in our population who are HIV positive. We have one specialist who helps our generalists do perfect HIV care. 99% of our HIV positive people are in relationships, 98% getting perfect services, and 87% with undetectable levels of virus. There is no HIV clinic, no HIV specialist you go see. It's all done by generalists supported by a specialist. Just one example of repeat over and over. And then since we don't have time to get into our villages, we support tens of thousands of people in very remote locations with completely different alternate workforces. We have community health aides, which are mini medical people, behavioral health aides, many behavioral health people, community health reps, many social workers, dental health aides who do drill and fill, and lots of oral health. And then we support this all through a very sophisticated telemedicine support process. We even have very standardized technology in every single village in Alaska, supported by pharmacist-managed dispensing of pharmaceuticals. And then this is all supported by an incredibly sophisticated infrastructure with a massively capable data mall, huge development center, workforce development investment, but it's all based on what the consumers and the people and our customer-owned and customer-driven people say they want and need. All of us in senior leadership together spend about 40% of our time deeply embedded into communities and voice of people and so forth. We don't just have customer voice occasionally on the side. As Christine said this morning, Christine Bechtel, this thing ought to be driven, owned, managed, and driven and designed by the people who use the system, and your committee ought to have at least 50% of its membership be patient reps and customer owner voice. And with that, I will stop for now, but we've spent 25 years redesigning this entire thing stem to stern, and we've answered every single question from measurement to staffing to system flow to design to how you bring specialists to how you handle transfers, even in inpatient. We believe in pull discharges from hospitals, not push discharges. So it's all been completely worked out here over the course of 25 years. I'd love to share way more in person, and I challenge your committee to come and get to know us more deeply. Thank you.